All right. So aloha everyone and welcome to the second State Epidemiologic Outcomes Workgroup SEOW quarterly meeting for this year. My name is Connie Emery and I am a junior epidemiologist on the SEOW core team from the Pacific Health Analytics Collaborative, also known as PHAC, at the University of Hawaii at Manoa Center on Aging. And I am here along with Bobby Doe, who is our lead data analyst, and also Nicole Siegel, who is our graduate research assistant. So we hope everyone is having a great year so far. And to start off our meeting, we're going to have a quick overview of the agenda. Okay, there we go. Okay, so to briefly go over our agenda, first we will start off with the welcome and a quick overview of the Hawaii Strategic Prevention Framework Partnerships for Success project and the SEOW. Next, we will have Ayada Bonilla, the State Educational Specialist from the Department of Education, present an overview of the School-Based Behavioral Health Program, which will be followed by a Q&A and then a 10-minute break. After that, we will have Tamara Whitney, Program Coordinator from the State of Hawaii Department of Health, and Michele Nakata, the Supervisor for the Dispensary Licensing Section, who will present substance use related data relating to the Medical Cannabis Registry Program, which will be followed by a Q&A, and then we will close with our closing remarks. Okay, so let's begin. I'm gonna do a brief overview of the Hawaii Strategic Prevention Framework Partnerships for Success grant. All right, so the SEOW is a part of the Hawaii Strategic Prevention Framework Partnerships for Success, SPF-PFS for short, which is a federal grant funded by the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. The purpose of the SPF-PFS is to strengthen and enhance Hawaii's prevention system to promote well-being and reduce the impact of underage drinking among persons aged 9 to 20 in Hawaii's communities. The SUW is a partnership between the Department of Health, Alcohol and Drug Abuse Division, also known as ADAD, the University of Hawaii Center on Aging, and interested community stakeholders. The SUW collects, analyzes, and reports substance use incidents and prevalence, as well as provides technical assistance and training for state and community stakeholders. And the SUW comprises researchers, epidemiologists, data managers, and other professionals involved in research, data collection, and utilization pertaining to underage drinking and substance use. In addition, we conduct quarterly meetings where individuals and organizations have the opportunity to share their substance use related data. And that is a quick background on the SPF, PFS, and the SEOW. Okay. Before we begin with our presenters or guest speakers, there are just a couple of reminders that we wanted to go over. So we are using the Zoom webinar format, which may look a little different from the Zoom meetings that everybody is used to. Attendees are muted and videos are off. So presenters and hosts are not able to see the attendees and the attendees cannot see themselves. Okay. If you have any questions, please send them through the Q&A feature located at the bottom middle of your Zoom window. If you have any comments or feedback, then please send them through the chat, which is also located at the bottom middle of your Zoom window, which is probably what everyone's doing right now, which is great. And okay, and you do not have to wait until the end of the presentation to submit your questions or comments. Please send them in at any time and we will review them at the end of the presentation. Okay, so without further ado, I would like to hand it over to the State Educational Specialist from the Department of Education. She will present an overview of the School-Based Behavioral Health Program. And please join me in welcoming Ayada Bonilla. Let me go ahead and stop sharing.
Good morning, everyone, or afternoon. See, this is how Fridays are with the Department of Education. We just lose complete track of time. So good afternoon, everyone. Thank you, Connie, for the introduction and the opportunity to share about my program, with you folks today. So I'm going to go ahead and share my screen. Add in present mode. And how is that? Oh, let me go back. There we go. Are we good? Okay. So thank you and appreciate the opportunity today. When Connie extended the invitation, the original ask was for data, and I was sharing with her that we're kind of in this gray area right now with our program. And so hopefully I'll have an opportunity to come back and visit again when we do have a wealth of data to share with you folks. But for today, I'll give you a brief introduction to our program, and maybe there can be some alignment in terms of the data that you folks gather, and I can share that with my staff to help drive our program and the efforts that we do to support our students. So I'll introduce myself. So Ayada Bonilla, and I'm here to just share our school-based behavioral health program overview. So we have been supporting students for 20 years. So this is an exciting year for us. 2001 is when our program was established. So we are having our 20th anniversary this year. And I will date myself a little bit and say I have been with the program since day one. So it's really been an honor to work with the SBBH program since its inception and really see the development over the years and to be able to take different roles in the program throughout the years. So established in 2001, and it was actually in response to the Felix class action lawsuit. And that class action lawsuit was really in response to what was felt to be a lack of mental health supports for our students in our schools. And what came of that was the Felix consent decree. That Felix consent decree established the school-based behavioral health program. And the main focus 20 years ago was to ensure that students who were experiencing what you see there, which is social, emotional, behavioral, or any mental health difficulties that might have been impacting their function in school, would receive the appropriate supports they needed. So it was really to focus in on students who might have qualified for special education, or students who are under like a 504 plan, which is our disabilities plan. So in the 20 years, the focus went from looking at supporting students at that kind of more intensive need, the special ed, the disabilities group, and really looking at how we can provide a continuum of supports. So what we are now doing is embedding the SBBH program into what we call the Hawaii multi-tiered system of support. And this offers really that, like I was mentioned before, that continuum of support. So now we're looking at not just intervention, and up till now we've been calling it prevention, but I like to call it promotion. We're looking at the promotion of academic, social, emotional, behavioral, mental, physical well-being. What are the things we can do to put into place supports for all students so that students are thriving? And then if the need develops, we are also on the other end of that spectrum to provide the intensive supports for students who need it. So this is kind of a very brief snapshot of what the Hawaii multi-tiered system is. And it consists of these 4 components. And so what I'm going to do today is really walk through how the SBBH program aligns with these components for our larger department. So the first one is foundational beliefs. So this is really looking at what is the why behind our work. What drives the supports and services that we're providing our students? What is our intention? What are the outcomes that we are seeking? The data-driven, team-based decision-making component really looks at this, the part that you folks would probably get excited about, the data. It's ensuring that the decisions we make aren't just because. We have our intention, the why, but then we're looking and connecting it to what's really happening. What are the issues, the concerns, the strengths that are happening with our system? and with our students, and really aligning our programs and supports based on data. The next piece is another piece you folks will probably be interested in, is the universal screening and progress monitoring. So this is really looking again back at the data to say, hey, are the things that we're doing, are they having an impact? And are they affecting the outcomes that we're aiming for? And if they're not, we need to start doing some realignment. The next piece and the final piece of the components is that multi-tiered system of supports. And that's really looking at, do we have enough supports for all of our students and the different types of students that are on our campuses? So if you look at that triangle, you'll notice that it's got 3 tiers. And basically what that is saying is that we have supports that are offered at that foundational level. Those are intended to impact all our students. And we're really looking at about 80% of our students that are going to respond to those school-wide supports, and that'll be enough for them. That'll be enough for them to thrive in the environment. Then at that second tier, this next section here, we're looking at maybe about 15 to 20% of our students that might need some targeted interventions, some targeted supports, maybe like some small group interventions to help them meet those outcomes that we had aligned in our foundational beliefs. And that very tip of our triangle is where our focus started 20 years ago, and probably where we deliver most of our supports and services. And that's the tier 3. That's those intensive, individualized, direct, one-to-one mental health services that we provide for our students. So right now we're looking at revamping our SBBH handbook. And that's what I was saying, like right now we're kind of in this gray period for SBBH where we're having to kind of shift to meet current needs. And we had a handbook from 2005, and I don't know how we existed on that for so long, but we're really in the process of looking at current needs, current data, and shifting our vision and our mission. So aligning our foundational beliefs to the bigger department vision. So for us, we're really looking in the spirit of Lokahi, right? We're coming together. We want to ensure that we have this united front when we're looking at student well-being. And our hope is that we, as the program, are going to promote that overall educational, physical, and mental well-being for not just our students, but the school communities. So that's our teachers, that's our families, that's all the folks that are invested within the community that surrounds our schools. And I'm going to just go back real quick. And I'm like, oh, I only have a half an hour, so I apologize if I'm going too fast. But the one piece I wanted to highlight here is that we're looking at overall educational, physical, and mental well-being. And you'll see there that's that physical piece. So part of behavioral health, and probably preaching to the choir, but we're really looking at the behaviors that are going to impact not just how we think and feel, but our physical well-being. And that's when we see students who are utilizing substances to kind of self-cope and things like that, that's really impacting many of these areas. And so while the SBBH program doesn't really have a specific substance abuse program, and we don't really target that as a specific area of concern, what we do instead is really try to develop the skills so that students can make decisions that are going to be better for their health, more informed decisions that are going to impact them in a more positive way. Our mission, again, we're circling back, is we're going to use that multi-tiered system, those 4 components, to really get to the outcomes that we're shooting for. And because our whole department is utilizing this multi-tiered system of support, it's real easy to align our efforts with the efforts that are happening with academics, with health education, because we're all speaking the same language here. So who are we? Who's our collective group that's working in Lokahi, right? It's these folks. And I started off in the behavioral health specialist, and I was one of those for 16 years of my career. And the behavioral health specialist, what their focus is direct services. So the BHSs is what we call them, are really providing that one-to-one direct support through individual counseling or group counseling. And we're the folks that are providing the students the skills they need to make those responsible decisions that hopefully are going to reduce whatever substance use and those kind of activities that you might participate in. The next group is our clinical psychologists, and um, some do provide direct services, but there's a lot of diagnostic assessments that happen with that group. And they're really looking at our most intensive students and helping direct the supports and services that those kiddos get. The next group is our school psychologists, and they're kind of like the in-between. They're helping the behavioral health specialists and our families and our schools align with this system of support. So they're really walking a school team through how do we ensure that a student gets the supports they need. And if it's a behavioral health specialist, then they're helping connect that student to the behavioral health specialist and ensuring that services are being delivered. And the last group that's within our larger SBBH program is the school social workers. And they're our frontline to our families and our parents and our guardians. So when a student is not engaging in school, they're the ones going and doing the home visits and checking to ensure that the family has basic needs covered and connecting those families to community resources. So how we look at our data is through this process. So we're really, anytime a student's concern comes up, what we're utilizing is the student support process. And that's what you see in front of you right now. And so basically a concern can come in, and that concern can come in from anyone. So it could be a parent, a teacher, a school staff member, a community member, a counselor, or even the student themselves. So they can present a concern in any of those areas. It could be academic, mental health, social, emotional. That concern gets presented. And then what the team does is they look at the data. What is the story of this student? What does the data say about what's happening for this child right now? Once we look at that data, we use that data to make some informed decisions. And we're looking to define needs and connect it to the support that that student needs. And I'm going to walk us through a little bit more detail this process. So the data that we look at are these things that you see here. So these are all the data that is available to us at our fingertips. So what the intention is with the student support process is not to be going after new data right away, but to really look at what is the current picture that we see. And so we're tapping into attendance, we're looking at health cards. How many times does the student go to the health room? And why is that student going to the health room? We're looking at report cards, social history. What are the parents saying? What are the experiences they're having at home? We're also tapping into pediatrician or private therapist. And then we're looking at observations. And the purpose of showing you all of this data is to kind of share that we're not just looking at a singular piece. And again, it's preaching to the choir, it's important to, yes, have all your separate data pieces, but to really look at them collectively and see what story they're telling together. So this for me is the most important piece. And this is this level of inquiry that I hope and expect my school teams to really go through. And you folks might have more questions that I should add to this list. And I know there's a wealth more that we could be asking, but at a minimum, we really want school teams to be asking these questions. So a concern was expressed. Do we have enough data to really determine what's going on? Do we have enough evidence here to support any decisions that we make? Can we tell when are these behaviors occurring? Where are the concerns happening? What do they look like? And why? And oftentimes we'll see like, oh, maybe the concern is just happening in math class. And that's the only classroom this is happening in. And in order for us to determine that, we need information from the social studies teacher, from English class, from PE, so that we can get that full picture. Is the why related to things we can change? And do we have folks at the table who can really speak and address the why? Some other things that we look at are, is it a skill problem or a performance problem? So is it that the student, if we ask the student, could they perform the task? Could they do the thing that we're asking of them? Or do they not know? And often this comes up with behavior because we teach math, we teach language arts, we teach history, but we don't always teach behavior. There's kind of this assumption that if I tell you to sit down, be quiet, and focus, you'll know how to sit down, be quiet, and focus. And that's a wrong assumption. Some students haven't practiced that, don't know the basic pieces that are going to allow them to demonstrate that for you. And so we need to answer that question. And if it's a skill problem, then it's on us to ensure that that student receives those skills so that they'll be in a better position to succeed. And then the final ones are really looking at, well, how intense is this concern? Because we have different staff on campus that can provide different levels of support. And while SBBH does look at participating in that promotion for all students, our focus is at those more intensive levels. And then what are the supports and services needed to address the student's concern? So team is sitting down, they're looking at all the data, they've identified concerns with mental health, they've identified some decision-making or some coping issues that the student is having. And they've determined, you know what, the issues at a magnitude that really require some really intensive individualized supports. Then we turn to our SBBH or BHS and we say, okay, the student would really benefit and needs behavioral health services. So at this point, we're really looking at, okay, now we're looking at that tiered system. We're at the top of the tier, but what's in there? What's in that tier 3? And what are the things that we provide there? So for us, I'm excited that we're really moving into this provision of evidence-based practices. And we're utilizing a system called PracticeWise. And what they've done is really looked at all of the different programs out there that are used to address different concern areas. So like Coping Cat is a curriculum that addresses anxiety. But what they did was they went through and they looked at all of the different kinds of skills that that curriculum focuses on, and they pulled them out and they're saying, okay, that's a great program, but here's just the skills you need. So you don't have to buy the program, but let's just teach you that skill set so that if a student is experiencing anxiety, you could do that. But we're also going to teach you the skills to help with a student who's experiencing depression or anger management, because it could get very expensive to buy a whole bunch of curriculums. But what they've done is streamline the process and really looked at what are the most effective strategies that you could use to address all different kinds of behaviors and concerns. So my hope, if I do come back by next year, because we're really doing a strong push for that this year, we're going to start collecting data on the practices that our direct service providers are using and what's the impact of those practices. And we're going to start looking at the data and determining, are these practices having the impact that we're hoping? So right now, some of the sources that we look at to help us with that universal screening and progress monitoring, right? We're looking at being able to identify the students that need the support. So yes, concerns will come up, and we all know there's students that raise the red flag on their own through their behavior, but then we have a lot of students who are internalizers, ones that aren't really going to be picked up through these kinds of data systems. And some of the ones that we use are our electronic comprehensive student support system. And so that's where folks enter grades, they enter progress monitoring reports. We use that for our service logs. Other things we use are the behavior intervention management system. That's our progress monitoring tool. And another one is our longitudinal data system. And all of these, what they do is provide kind of an early warning system of red flags. And so they'll highlight, okay, this student has issues with attendance or discipline, or their grades are low. And so they'll get the little red flag on there and call attention for us. But something that we're really looking to bring in this year for, post-pandemic is that we know there's going to be a lot of students that aren't going to be raising these red flags through these early warning systems. Like I mentioned, those internalizing kids. And so we really need to come up with a system to screen for those students. How are we going to find those kids and connect them to the services that they need? So these are the sources we have right now, but by time next year, I do hope to have more at our fingertips so that we can really look at identifying students across the board. So I just wanted to give you a snapshot, since you're our data folks, of our longitudinal data system. So what's that last thing on the list? And these are the things that are on our early warning system. So if you'll see here, we're really looking at attendance, discipline, curriculum marks, so that's the grades they get in school. And the reason that it's separated by secondary and elementary is that our secondary uses the GPA format like an A, B, and our elementary school does standards-based, so progress towards standards. So the marks are different there. GLOs are our general learner outcomes. So those are those skills, right? Are you a self-directed learner? Are you an ethical user of technology? So not so much curriculum, but more of demonstration of behaviors. And then these last few ones are our assessments and our universal screeners. And universal screeners here are specifically academic. So as I was mentioning earlier, we don't have universal screeners for mental health, well-being, social, emotional needs right now. Here's my little tidbit of data I can give you. I have other data, but because of COVID, and I know this is something that you would anticipate, is all our data is a little wonky, and I didn't feel comfortable utilizing this past year's data as a good snapshot of how things are going, because participation in those progress monitoring and the data entry has not been similar to years past. And I just came on board maybe about a year ago, and in looking at the data that was collected in prior years, that data wasn't clean either in my book. So I'm establishing a baseline this year. So really looking at where we are right now, and then we're going to implement all of these evidence-based strategies and a new data collection system. And then the hope is that moving forward, we'll have cleaner data that's really going to support us in the decisions we make to drive our program in the future. So what you're looking at here is basically that the SBBH program supports about 5,600 students across the state. And these students, many of them are those students who are in special education or under a 504 disabilities plan, a modification plan, forgive me. And some of them, though, will be those school-wide kiddos that just needed a little support, like a crisis support, or maybe a walk-in, they came in just to check in with a counselor, or participate in a targeted group, like a social skills group for a limited time. Of those students, though, you'll see, if we go back one slide, there's that high risk column, so that red block. And of our 5,600 students, 5,000 of them have at least one high-risk area in their records. So either their attendance is at high risk, their curriculum marks is at high risk, or their discipline, or they have multiple. So there's a reason they're receiving our services, because they are demonstrating some need that really needs attention and support. One of the big things that's being discussed right now is attendance. And so overall, we usually aim for 95% attendance rate for the department. And so all things considered, this was the snapshot from just a few days ago of our group. It's not as bad as I was anticipating. So we're about 87% with the majority of our students attending. And so I'm feeling positive that as we return to face this coming fall, that we're going to see this attendance improve, because our students in general really benefit from that personal connection, and have definitely struggled with the online virtual platform that they're participating in now. So really looking for an uptick in that data. A positive is our incidence is extremely low, right? They are not in a classroom setting. They're not being, they're not having to participate in the social dynamics that face-to-face school offers. And so there is a major decline in incidents. And so overall, our discipline is looking amazing, but it isn't a true reflection of generally what we see. The interesting piece is that it was extremely low in the first few months of distance learning. But then as we got closer to the end of the school year, students who generally would get incidence referrals for like social type things started learning that they could demonstrate similar behaviors through chat rooms and things like that. And so then we started seeing an uptick in referrals of misbehavior on online platforms. So we'll see what happens there when we return to school. And so that's kind of like the big overarching overview. And I apologize, I kind of went through that very quickly, but the hope is just to kind of give you a snapshot of what our program offers. And I really do hope that if there's an opportunity for me to rejoin your group in the future, that I'll be able to show you the data that we collected over the year and some of the analysis that we did. So with that said, thank you. I really appreciate your time, and I'll give you an opportunity to ask any questions that you might have.
Perfect. Thank you, Ida. Okay, so now we're going to move on to questions. So if you haven't already done so, please type in any questions that you have into the Q&A feature at the bottom of the Zoom window. I see we do have a few there. Let me take a look. Okay, I can see them here. Okay, Nicole Fukuda, she's asking, is this strictly K-12 or is it DOE preschool included, SPED preschool also included in the data and program?
So generally for supports and services, it's actually pre-K through high school. Although the supports look a little different for our pre-K students, and oftentimes it's a lot of support of the adults in the classroom. Our pre-K kiddos tend to have one-to-one supports often, and so we are providing behavior support plans and really looking at helping the adults with the environment that our pre-K kiddos are in, and helping the adults with the responses that they provide for our students to help guide their behavior. So not as much counseling, direct types of services for our younger students, but we are definitely connected to that program.
Got it. All right. Okay, our next question comes from John Valera. And his question is, in what way are school counselors involved in the SBBH? And then also, who makes the referral to the SBBH?
If I can go, forgive me, I'm going to speed through my slides backwards. Okay, so great question. So if we're looking at this pyramid, and you'll see there's the two lines that are kind of going up and down on the side of that pyramid. And SBBH, our focus area is that tier 3. But then you'll see that student support team starting from tier 1 and moving up. And then there's that gray area in the middle. So our counselors, our school counselors, their focus area tends to be tier 1. They do a lot of school-wide supports. They're doing supportive social emotional learning curriculums. They're helping with tier 1 classroom type supports. And what happens is, as a student's needs escalate, or as we start identifying students who might need more supports than what the counselor can provide, because okay, students going into crisis pretty regularly, that's where this nice handoff happens with our SBBH staff. So what happens is, if you can see, there's those gaps in between the levels, and it says review through student support process. So what'll happen is a student maybe that might be in that tier 1 starts kind of popping up, right? We start seeing some needs develop. And those referrals, as I mentioned earlier, can come from anybody. So a parent could walk in the door and say, I have a concern about my child, or a teacher might say, hey, I've been trying classroom supports and they just don't seem to be effective for this student. I need some more additional support. Could come from admin, it could come from anybody really. And so once that concern comes in, through that student support process, they're really going to identify, okay, what are the needs of this kid? And can the counselor provide them? Maybe the counselor offers a fantastic social skills group, which is perfect for the student's needs. Or maybe the student is just having crisis every day, and the counselor's, what the counselor has to offer in terms of services won't match that student need. And so once it becomes that intensive, then it's that handoff to the behavioral health specialist or the SBBH staff.
Got it. All right. Okay, our next is just a comment. This is from Rosemarie Vergara. She said, thank you. Your presentation was very informative.
Thank you.
Thank you, Rosemary. All right, Susanna Helm, she is asking, how do folks become BHS? What are the qualifications? How do people apply? We work with lots of undergrads. Do they have to become teachers first? Or is there another route like BA in psychology or social work?
I'm going to scooch back to this one. So depending on the role group, the qualifications will differ. So for behavioral health specialists, and I'll say this lightly, is that right now there's not a requirement for our direct service providers to be licensed. But what is expected is that our behavioral health specialists, our social workers, maintain a master's degree level in either marriage and family or a mental health area. So if they get their license, they're getting that mental health license or the social worker license. We don't have a license for our school psychologists right now. So looking for master's level for the school social workers and our behavioral health specialists, and a counseling field for our school psychologists, looking for a advanced degree in school psychology, and our clinicals are our staff, are the one staff that the requirement is a license. So, and how you become one. So it's just applying through the Department of Education. And so they're all listed by role group. So if you just go in and there's different levels of behavioral health specialists, depending on the amount of experience that you come into the application with.
Thank you. I was actually wondering, Ida, what were some of your most memorable experiences during your time with the SBBH program? Because I know you've been working there for a while.
Oh, how much time do you have? No. I have so many, but honestly, I have certain students that I hold near and dear to my heart. And I think the ones that I hold the closest are the ones that really came to me where staff had lost hope in them. And they really came to me with what are we going to do with them? I want them out of my classroom. And so really, like, I, as a behavior health specialist, my number one was building relationships with my students. And so that was just my end goal. I need to create an environment in which the student trusts me, even if they don't trust anyone else on this campus. If I can establish that trust with me, what they'll do is enable me to walk them through making good decisions in other environments and on the campus. And so, I just had some students that just had these amazing personalities, and I loved being able to connect with them and then be able to like introduce those little personalities to their teachers who really just didn't see them for who they were, and all their quirkiness and their creativeness. And one of my, like, when I first started, I just loved that I would do lunch bunches. And my office was the JPO closet. It was where, I don't know if anyone knows what a JPO, it's a junior police officer, and they didn't have an office for me. And so it was a closet that was right across from the cafeteria where they used to have the helmets and the raincoats. So they cleared that out. It was like this stinky little closet that I painted. And I would have lunch bunches in there with my students. And I would love that other students would come by and be like, well, how do I sign up for your class? How do I, and my kids would be like, well, you have to have behavior problems. And I'm like, no, let's not say that. But it was great. It was just connecting, and really I just loved when my students knew that I was there for them. And that when they saw me, even if they were in crisis mode, it was just like, okay, I know she's got my best interest at heart. So, but yeah, one-to-one, I can tell you all the juicy details. Like there's some great stories. I've been bitten. I've been, it's there's been many adventures. I talked dinosaur for a very long time because that was the only thing one of my students would communicate through. So yeah, they're fun.
Thank you so much for sharing. I see another question in chat, which is, have you noticed any trends, good or bad, since you began this program?
I would say that personally, a trend that I've been seeing with the department is that when I first started 20 years ago, there was this beautiful focus on social emotional learning, positive behavior supports, whole child. And unfortunately, with the shift of expectations from the larger department, the federal government, on what our schools needed to produce, with No Child Left Behind, a focus really went to academics. And there was so much focus on academics that we saw this decrease in attention to behavior and social emotional. And now what I'm seeing now is the impact of that. And that we have a lot of students that don't necessarily have those competencies developed because it was just about the academic area. And so there's this greater need right now for not necessarily those intensive supports, but more for school-wide development of all these social emotional skills for much more students. Like we're just having to really work with all of our students to really develop those skills. And it's unfortunate because we really were ahead of the game so many years ago, and we just lost focus, unfortunately. So now it's like swinging back in that direction. And COVID, I think, even though it had just such detrimental impacts for so many people, it really highlighted we need mental health supports, and we really need to be talking about this, and it needs to be spoken about it in a very positive way. Mental health is a good thing. and we need to promote it. Everybody needs to promote it. And so for me, it really shined a spotlight on the importance of the work that the folks in our program do. So I'm hoping that sustains and we really keep with that momentum.
Got it. All right, Ida. Okay, any more questions, anyone? Last call. Oh, we have one last question. How do the teachers fit into this?
So when we look at that data-driven team-based decision-making, so the teachers are the front line. They're the ones who really they are creating the environments that our students are existing in. And so the teachers, I love them, and they are essential in delivering those school-wide supports and creating that climate for our students to thrive in. But we recognize that the teachers, they don't necessarily have the time to dedicate one-on-one supports for students that need it all the time. So when they are reaching a point where they recognize that my classroom supports aren't enough to support this kiddo's needs, then they are part of that decision making, right? They are coming to the table and saying, I have concerns for this student, and here's my observations. Here's all the things I've done for them. And so they're part of that group to really look at how can we create a plan that's going to wrap around this student. Teacher's going to continue to do supports in the classroom, and maybe they're going to do different ones that can be adjusted to maybe make that environment more supportive for that kid. But then we're going to come in and support not just the student, but the teacher as well. So we're really looking at if a student gets a diagnosis or having certain emotional needs, does the teacher have the skill set, right, to be able to work with that student in the most effective way? And they're not counselors, so it's our job to really share with them, here's some skills and here's some ways to approach the student so that you're going to have better success building that relationship with them. So really acknowledging that the teacher is such an essential piece of that team and working alongside them to support that student. So hopefully that answered the question.
Yes, absolutely. Thank you. All right. Thank you so much, Ida, for the awesome presentation and for answering all of our questions. We're so thankful. And we would love for you to come back, of course, anytime you're ready. We're ready to.
My last slide there. So if anybody wants to reach out by email, please do. And thank you again. I really have appreciated your time and your audience. So thank you again.
Thank you. All right, we're now gonna move on to our 10-minute break to give us some time to transition into the second half of the meeting. And then, so feel free to stretch, relax, grab some water, and we'll see you back at 1 o'clock. 2 o'clock, my bad. See you at 2.
All right, welcome back everyone. We're about to begin the second half of our quarterly meeting. Next up, we have the program coordinator and the supervisor for the Dispensary Licensing Section from the State of Hawaii Department of Health, Tammy Whitney and Michele Nakata, who will present substance use data related to the Medical Cannabis Registry Program. So please join me in welcoming Tammy Whitney and Michele Nakata.
Hi, everyone. Thank you for having us here. I'm just going to share my screen and we'll get started. Okay. Again, thank you for having us here to speak to you on behalf of Hawaii's Medical Cannabis Program. Just to kind of give you a picture of what the other states are, doing, or what our country is looking like these days is there's, I'm sorry. medical use or cannabis use has been on the rise. We now have majority of the states that do have some access to cannabis, whether it's a CBD only program or a more comprehensive program like Hawaii, or states that also have a medical comprehensive program, in addition to also having an adult use or recreational program. Taking it back a couple of decades, Hawaii and California were the first states to implement a medical program. California did so by a ballot initiative, and Hawaii did so through legislation. And then year after year, more states, joined their initiative, all to, promote the health and welfare of their citizens. So, like I said, Hawaii's had a program since 2000. We are a medical only state. It was housed under the Department of Public Safety Narcotics Enforcement Division, and then it was later transferred to the Department of Health in 2013, and the registration program became fully operational in the Department of Health in 2015. At that same time, the dispensary system was established in the Department of Health under the Office of Healthcare Assurance. It took a little while to get up and running, but the dispensaries began to open its doors in 2017, which I thought was pretty remarkable, in that it just kind of opened up access for patients who, otherwise didn't really have the access that they needed. They were able to go into a licensed facility to purchase their medication. So I think that was a really huge moment for our program. Later, we broadened our program to include a process for patients who didn't live here, who were visiting, to come and register to be able to use cannabis, which was also really great. And I think it's helped a lot of people. And then in 2020, we joined the Cannabis Regulators Association, which is a national organization of state regulators, really providing resources to each other to help each other make informed decisions regarding like everything cannabis. So in the Office of Medical Cannabis Control and Regulation, we have two distinct sections. Our mission is to ensure safe access to medical cannabis for qualified patients. The Dispensary Licensing Section oversees and provides a regulatory framework for the 8 licensed dispensaries to operate in, and also monitors the quality of medical cannabis products for registered patients. The patient registry provides safe access to cannabis by issuing a registration card, or what we call the 329 card, for qualifying patients. Overall, we are, both programs are working to balance the health and safety needs of the patients as well as our public. What's the eligibility criteria to register? So before you can even begin to use cannabis in our state, you have to register with our program. We have 2 different tracks. One is our out-of-state program for visitors, and then we have our in-state process for people that generally live here more than 6 months out of the year. So all you would need to be an in-state patient is to have a valid ID. You'd have to be certified by a medical provider registered in the state of Hawaii. For our out-of-state patients, you'd need a valid state ID from your home state, and also be a valid registered patient in that same state. And both out-of-state and in-state patients must be certified as having one or more of the debilitating medical conditions recognized in state law or Hawaii state law. And then here's just a list of our debilitating conditions, all of which were added at some point through our legislative process, all except for amyotrophic lateral sclerosis. So this was added through our petition process, which we hold yearly. And it's a process where a patient or a provider or a potential patient can submit a petition to us to add a certain condition. If we accept the condition or if we accept the petition, we will review all of the literature available, hold a public hearing to hear the voices of, our community, and then the Director of Health will render a decision. This was the one condition that was added. We did have other conditions petitioned for, such as opioid use disorder, depression, insomnia, and anxiety, but there wasn't enough evidence to support adding those conditions. And then here's just a breakdown of our patient population by condition. So patients can be diagnosed with more than one condition, so it won't add up to the valid number of patients that we currently have. For our minors, they are generally certified as having seizures or PTSD, and then our adults are certified as having severe pain, and then followed by PTSD. So after a patient is determined eligibility, what's the process like? Patients will go and make an appointment to see their medical provider. If their medical provider feels that the benefits outweigh the risks and agrees to certify them for medical use of cannabis, the patient will then go online, complete an online application, submit it to the physician, who will go online and certify their condition in the application, and it will be sent over to us to review. Once we review and approve the application, we will email the patient directly to let them know that they can log into their account and retrieve their 329 card, which looks like this. So on average, in terms of our volume that we're seeing in a month, we receive about 2,266 in-state applications a month, and we process about 2,195 of those. As far as our out-of-state patients go, we receive 315 applications a month and process about 257. Our average turnaround time from when we receive the application to when we approve it is generally 3 to 5 business days. And we do expedite applications for any minors or anyone living with cancer or anyone who's in hospice. And then here is just a breakdown of our valid patients by year. We've grown over the years since we've had the program. I think it's about 1.8% a month. And by 2020, valid patients made up about 2.1% of the total population in Hawaii. And then, so who is our average patient? What do they look like? The typical patient is male. He's 45 years of age or older, lives on Oahu, and is certified as having severe pain. And as of March 31st of this year, we had 32,193 in-state patients. And then the pie graph just kind of shows you where our patients are from. Majority of them are on Oahu, followed by Hawaii, Kauai, Maui, and then Kauai. Here is our patients by age over time. As you can see, the red line on the bottom, those are our minor patients. They make up less than 1% of our population, and it's remained pretty steady throughout. The majority of our patients are between the ages of 36 and 75. Our oldest patient as of March 31st is 101, and then our youngest right now is 5 years old. So once a patient gets their medical cannabis card and they saved it to their mobile device or printed it out, they can begin to use medical cannabis. And what that means is that they can acquire it, they can cultivate it, distribute it, possess it, use it, or transport it, all to alleviate the symptoms or effects of their debilitating medical condition. So they can use cannabis, but there are, certain conditions to using it. So you're not allowed to use it in any public space in a way that endangers the health or well-being of another person. If you're transporting it from, the dispensary to your home, it should be in a sealed container, not visible to the public in any way. Also, since it is still considered federally illegal, there are no state protections if a person chooses to transport it inter-island. So all patient registrations and grow sites are subject to verification. All complaints are investigated by law enforcement. And whenever you're in possession of cannabis as a patient, you should always have your 329 card on you at all times and also have a valid ID to present to law enforcement should, it be requested. Also, all smoke-free laws do apply to cannabis as well as tobacco. So if you remain in strict compliance with our rules and laws, you may be afforded certain protections. And also added in 2015, which I love, is we have non-discriminatory language based solely on one's status as a patient or a caregiver with respect to school enrollment, housing, medical care, and custody. And this is really just so that patients who do choose medical cannabis as a form of treatment feel no less secure than someone else who has maybe chosen a more, like, air quote, traditional treatment path. Right now, there's no protection under state law for employment situations. And we do, whenever we're asked, we do refer patients back to their employer's drug policy for guidance. There's also no requirement for the department to verify one's type of employment. So we don't check before, we don't ask you what type of job you have. We don't check to see if, you're a teacher or a bus driver or, a pilot or something like that. Okay. And so patients can use it. There's conditions, there's some protections, and now there's some options, right, for patients. So a patient can grow their own cannabis if they choose to. If they do, they can grow no more than 10 plants at a single location. Every plant must be tagged with the patient's registration number and expiration date. They can have no more than 4 ounces of usable cannabis on them at any given time. Also, a patient can, grow their own, as well as they can go to a licensed dispensary and purchase cannabis. If they choose to go to a dispensary, you can purchase 4 ounces within a consecutive 15-day period, but no more than 8 ounces in 30 days. Patients also have the option of designating a caregiver. And so this is a person who's over the age of 18 who has agreed to help the patient with, either growing or just going to the dispensary or helping them administer cannabis. And the ratio right now is 1-to-1 for adults. If you have a child, both parents can be a caregiver for their child or for all of their children, should they need it. And right now, so about 8% of our patients have registered a caregiver to help them. Also, we do have about 60% of our patients who have expressed their intent to grow cannabis. And I say express their intent because we can't and don't know for sure if they're actually exercising that option. But on the other hand, we do have 40% of our patient population who have explicitly said they are not growing cannabis. And then we believe they're likely to be using, the dispensary system to get their medication. And on that note, I will hand it over to Michele to talk about the dispensary system.
Muted. Okay, thanks, Tammy. So I'm going to talk very quickly just to give folks an idea about the dispensary program. Some familiar faces in this slide. These were the legislators that were very instrumental in implementing the dispensary program. Next slide, please. So there, by state statute, there were 8 licenses established statewide. And as you can see, there are a total of 17 retail dispensaries now open. The state law does allow the Department of Health to issue additional licenses based on patient need. But as of this time, not all of the licensees have opened all of the retail locations or their production centers that they're allowed to establish. As Tammy mentioned, you know, we don't think that all patients are fully utilizing the dispensary system yet. So that's the reason why we've chosen not to issue additional licenses yet. Next slide. So one of the primary concerns that was raised when establishing a dispensary system was, of course, that we're granting licenses to people to grow cannabis and grow cannabis in substantial amounts. And so diversion or the risk of cannabis exiting the system and going into illegal sales, or inversion, which is basically bringing illegally grown cannabis into the legal system, were strong concerns. And as a result, Hawaii, like virtually every other state that has implemented a cannabis program, employs a electronic seed-to-sale tracking system. What this does is it accounts for every single cannabis plant and all the plant material from each cannabis plant throughout the system. It tracks it from cultivation through harvesting, through production of flower material for sale or manufactured products, into laboratory testing, and then retail sales to the patient. The only way that cannabis plants and cannabis material that is produced by each licensee can exit the system is through sales to patients or through destruction, and destruction is also strictly monitored. Next slide. Quality assurance testing. Hawaii requires that every single batch of final product be tested for a number of standards. We are unlike a lot of states that just do random sampling or periodic sampling. The licensees must test every single batch of product or flower material before it is allowed to be moved to being packaged and then going to retail sales. Next slide. Okay. Hawaii maintains what's called a strict vertical system, meaning that each of the 8 licensees is required to oversee everything. So they must cultivate, they have to manufacture, they have to package, they have to conduct all of the transport. They're responsible for ensuring all the laboratory testing, and they are responsible for retail sales. This is a picture of from a production center, 2 different production centers. We require complete indoor cultivation, but it can be either in an enclosed building, which is kind of the photograph on the right-hand side, or it can be in a greenhouse, which still has solid walls, but the roof, as you can see, is translucent, so it allows the licensee to take advantage of natural sunlight. And then they use different methods. The one on the left-hand side, they have a fairly sophisticated automatic watering and feeding system that's employed to help manage the plants. Next slide. These are just some photographs of plant material that's been harvested. Once it's harvested, it's dried to remove the excess moisture. This is a critical step in cannabis production. and it's also very important for product safety because the reduction of moisture also prevents the growth of mold, and mold is a significant concern, especially for inhalational use of cannabis products. Next slide. The licensees are also allowed to manufacture products. So there's a variety of things. The upper left-hand corner is keef, which is collected from the trichomes of the cannabis flower, and actually has a very high percentage of the cannabinoids that are present in the plant. The bottom left is rosin, which is created by pressing plant material, and it can be done under heat or it can be done at cold at room temperatures. The center is a photo of alcohol distillation, and then the far right is supercritical carbon dioxide. And you can see that depending on the process that's used to manufacture the products, the consistency of the extract is very different. Next slide. Okay. The types of products that are currently authorized, Hawaii does allow sale of flower or usable cannabis, but we do not allow the sale of pre-rolls or joints, blunts, spliffs. We also allow the sale, production and sale of what's called safe pulmonary administration cartridges or SPA cartridges. They are essentially vape cartridges, but we disallow the use of the word vape. As I'm sure you're well aware, Hawaii has a very strong anti-smoking policy and anti-vaping policies, and that's the reason for not allowing sales of pre-rolls and using the alternate terminology. We're also very strict on with regards to, because of the anti-smoking stance, we do not allow the sale of paraphernalia. That's associated with smokable forms. So the licensees are not allowed to sell rolling papers or rolling mats, although they are allowed to sell the devices for using the cartridges. And the reason why we allow that is because we require them to use temperature controlled, to sell temperature controlled devices that are made of inert materials. And the reason for that is to allow them to control the temperature of the oil as it's heated, to ensure that it's not that there's not inhalation of undesirable components that may be present either in the cartridge or in the device itself. In addition to that, there's a variety of solid and liquid ingestibles, things such as tinctures, lozenges, and capsules. Edibles were authorized at the beginning of 2020. We're still currently working on, I'm sorry, it was this year. We're still currently working on our administrative rules to allow for edible items. So they are currently not available in the dispensaries. They can sell topicals, which are things like creams and balms and lotions. And then there are concentrates like the photograph on the top right, which is shatter. And that includes things like rosins and other types of concentrated materials. Next slide. And this is just a peek inside a few of our retail dispensaries. They're actually really nice shops. The large photo on the left is Hawaiian Ethos. I think it's their Hilo location. The top right is Big Island Grown's, one of Big Island Grown's stores. The middle one is Noah Botanicals, which is an Oahu dispensary, and the bottom right is Cure Oahu, located on Kapahulu Avenue. Next slide. Okay. As Tammy mentioned, dispensaries can dispense up to 4 ounces in a 15-day period, and not to exceed 8 ounces in 30 days. I don't know how familiar you all are with how much that is in volume. When I joined the program at the end of 2018, I was really shocked to learn because it's quite a bit. So 4 ounces. which is basically a 15-day supply, is the equivalent of 2 sandwich bags. And depending on how much flower material you put into a joint, 4 ounces can make up to 400 joints. So it's quite a bit that they're allowed to dispense. Next slide. So similar to what Tammy showed as far as patient registrations, as the patient registration number, as well as the number of dispensaries, retail stores that have opened, you can see that sales have increased steadily. And in fact, last month alone, for the month of April, statewide sales exceeded $5 million. So a lot of stuff is being sold. Next slide. Okay. So one of this also aligns well with a comment that Tammy had made previously. So this basically shows that about 40% of patients are accessing dispensaries. I think one of the things that we have been trying to track, and we do want to take a stronger look at, is why this number has remained so static. It is the intent and the desire of the department. While we do believe that patients have the right to cultivate and manufacture within reason cannabis themselves for their use. Ideally, we do want patients to be using a legal, regulated, and laboratory tested source. And so it would be ideal, to start seeing this proportion of patients that are accessing the dispensaries increase, instead of essentially remaining flat for the past 4 years. Next slide. So this is another trend that we have been monitoring, which is the type of products that are being purchased by the dispensaries, by patients at dispensaries. And it is a topic of significant concern for the health department. So as you can see, the bottom dark green is usable or flower material, and that does still remain by far the most common item that is purchased and used by patients. And it's not necessarily to say that all of it is being smoked, because a lot of patients will take flower material and process it, into butter to be able to make their own edible products. However, one of our concerns is that lighter green color, which is the inhalable form, which seems, has grown substantially over the past couple of years. And we do think that, in some respects, this represents the use of the cartridges, which is understandable, because the cartridges are a more discreet means of using cannabis. Doesn't have the strong smell that flower material does. And it's not subject to a lot of the challenges that rolling up a cigarette and smoking it does have. But the inhalable forms would also include concentrates, and those tend to be very high THC content products, and as I'll cover, in the next few slides, the use of high THC products, the intensity of use of products is an increasing concern that the Hawaii has, as well as other states. Next slide. Okay. So I was kind of relieved when the previous presenter mentioned that she doesn't have a lot of data yet, because we are also in the same situation. We actually, the program, as Tammy mentioned, the new Office of Medical Cannabis Control and Regulation was recently stood up. It you know, we did the whole reorg, establishment administration. We established new positions, and I was super excited because we actually have an epidemiologist 2 position for the program. Started recruitment in February 2020, and then COVID hit. And because the positions were general funded, all of those funds were restricted. And we had to stop our recruitment. So we don't have a body yet to be able to conduct all of the epi work that we would love to see done. So, however, House Bill 200, which we're waiting for the governor to sign into law, will reestablish the funding for the position. So we are hoping to be able to initiate recruitment if anybody's really interested in doing cannabis related epi work. Keep your let us know. But anyway, so because it's been really sad. So we, you know, there is a optional BRFSS module for cannabis related questions. There were 3 questions. One of the things we did was scrape up some money and you know, at least pay for that optional model to be implemented this year. And the 3 questions that are included from this year are 1 on current use, 1 on mode of use, and 1 on reason for use. And something exciting that we learned just recently is the CDC, which up till now has pretty much avoided involvement in cannabis related things just because it's still federally illegal. They actually now have an office that is going to be assisting with cannabis related education and data surveillance objectives. And through that, Hawaii has actually been offered funding for implementing an enhanced optional cannabis module. So we've requested funding for that, and it will be 7 questions. It includes question 1 and question 3. But what they did was they expanded question number 2 to ask those specific questions about mode of use. So is, you know, in the past 30 days when you used, did you smoke, or did you vape, or did you dab, right? Or did you consume in an edible? So it will give us a lot more specific granular data about exactly how individuals are utilizing cannabis. Next slide. Okay. So sadly, because Hawaii doesn't have information, we look at a lot of the data that other states are collecting, and Colorado is one of them that has done a lot with regards to cannabis and public health concerns. So this was a recent report that Colorado released. And these are some of the more concerning trends that they observe that are things that we will direct our epidemiologists to be looking at when that person comes on board. So one of the trends was a significant increase in past 30-day use, or what we consider current use among adults. Also significant increases in daily or near daily use and consumption, as well as the perception that daily or near daily use does not have a risk of harm. And that, you know, in their latest data set in 2019, nearly half of the adults who report consuming cannabis do so on a daily or near daily basis. So frequency of use is an increasing concern, you know, with regards to adults. Next slide. Okay, so we do at least have some basic information regarding marijuana use in high schoolers as well as middle schoolers. This is some information for the high school YRBS data. And it actually looks pretty good, because if you look at it, it looks like, you know, lifetime use as well as current use as well as age of initiation are actually either flat or on a downward trend. So, people will look at that and a lot of the cannabis industry will highlight these specific things in their materials to say, see, it's not causing concerns among youth. However, next slide. One of the things that the Hawaii YRBS survey does show is a concern that although the top line is, whether the usual mode of use among high schoolers, smoking is dropping, but you'll notice that that kind of turquoisey blue line and the yellow line have shown, and it is a significant increase in the use of vaping as a mode of use, and then the other category. And so our concern, and the reason why we're happy that at least for BRFSS, they're breaking down mode of use for other further is there is a strong guess based on other states' data that the other mode actually includes use of very high THC concentration products, such as concentrates and using and dabbing as a mode of use. Next slide. Okay, and then again, pointing to Colorado's data, for their data looking at their high school students, concerning trends that they have seen are a significant increase in driving after recent use. So in other words, concerns related to impaired driving, increase in use of dabbing and vaping among high school students. And then similar, to the previous slide, although smoking seems to have declined, the use of dabbing has increased, and among in the 2019 data among students that report that they are current users of cannabis, 1/5 of them use dabbing as their usual mode of use. Next slide. Okay, and sadly, PRAMS data. So use during and before pregnancy is completely absent, and was very sparsely collected. We're still trying to, we'll be doing some follow-up to find out how we can start this up again. Use during pregnancy is a significant concern even after pregnancy, because there are concerns about secondhand exposure to infants. THC does cross the placenta barrier, so it does expose a fetus, and it also crosses into breast milk. So it is a concern also for breastfeeding women. Next slide. Okay. Another recent publication has, also highlighted concerns related to intoxications, and poisonings, inadvertent poisonings. Overall, this was a survey that, this was a study that I believe included Oregon, Washington, Colorado, and Nevada, I believe, data. It's very new. It just came out, I think, last week. But the things that they noticed is just in general that there are concerns over increased exposures and reports related to manufactured products, which again raises the concern of how high THC containing products, and then also that pediatric exposures have increased. Next slide. And so Colorado has also done a significant amount of scientific literature review. And so just to highlight a few things that their studies have shown and providing substantial evidence of a relationship for adults that THC can cause acute psychotic symptoms for adolescents and young adults. So these are individuals up through, I think they use the criteria up through age 25. Daily or near daily use is associated with future psychotic disorders. And use is strongly associated with developing psychotic symptoms into adulthood. We can, frequency of use is a concern because it is associated and strongly associated with failure to graduate from high school, and that even infrequent use, so less than weekly use, so kids that use maybe just on the weekends, is also associated with high risk use of future use of alcohol, tobacco, and other drugs. Next slide. And moderate evidence, so definitely that there is a positive relationship between them, but that the strength is not as strong as substantial among adults that use of marijuana with high THC concentrations, which what we use typically is greater than 10% THC. It is associated with future psychotic disorders among adolescents and young adults. Again, use of higher THC concentration is associated with future mental health concerns. And again, this points back to our concerns about the use of concentrates and dabbing as a mode of use. Weekly or more frequent use is also associated with not completing college for students who are enrolled. There's impaired memory, math, learning, it does interfere with learning processes, and it also increases the risk of suicidal thoughts and attempting suicide. Next slide. Okay. So much so that APA, the American Public Health Association, just recently updated its policy statement on public health approach for regulating commercially legalized cannabis, and there are 4 areas that they urge states to pay attention to is to ensure protections to children, youth, and other vulnerable and marginalized populations, ensuring that we minimize the harm to the public, and prioritize social equity, and monitor patterns of cannabis use and related public health and safety outcomes. Next slide. Should be almost, yeah. That's it. So happy to answer any questions.
All right. Thank you so much, Tammy and Michelle. That was an amazing presentation. We're now going to be moving on to questions. So if you haven't already, then please type any questions or comments that you have about the presentation into the Q&A or into the chat. And so it looks like we have some already. So there's one from John Valera asking, is this the first year that you are including the questions in the BRFS?
Yes, this is the first year. Hawaii's not ever previously asked cannabis related questions.
Gotcha, thank you. We also have another question from Susanna Helm asking for the Colorado data comparison to Hawaii. What is the age of consent for marijuana in Colorado versus Hawaii? Is it 18 or 21 years old?
That is a good question. I believe it's 21 you mean for adult use versus adult, or what we call adult use, which is basically recreational use. I believe it is 21 years of age. Most of the states that have moved to adult or recreational, or I think some states call it commercial cannabis, they treat it very similar to alcohol. And so age of use is 21.
Okay, Susanna Helm said, thank you. That's what I was wondering for recreational use in Colorado. And then John Valera has another question, which is, what is OMCCR doing to educate patients and dispensaries, given the changes in the field?
Tammy, you can talk about
Um, well, as far as changes to our program, we do try to educate patients, but it's been a lot of our educational efforts have been around, patient access, how to register. We really don't have a public health campaign in place, so to speak. I think one of the things that we were hoping to do when we did get the positions for the Office of Medical Cannabis was to launch a public health campaign to expand education beyond, just, the rules and the laws and stuff like that.
And that is something that we are hoping to do. I did mention House Bill 200, which basically refunded those positions that had been established. In addition to that, House Bill 200 also provided the program with a health educator position. And that's one of the things that, and it also provided us with funds for educational campaign. So that's something that we do want to work on, but it kind of goes hand in hand with the epidemiologists, right? We have generalized information, from what other states are doing or national surveys, but we don't have Hawaii specific information. So I think probably we'll start with some general messaging that, that's pretty consistent across the states. But eventually what we would like to do is start producing some Hawaii specific messaging.
Thank you. There's another question from Susanna about, are there any directions for our state regarding recreational use?
Hopefully not before I retire. Yeah, there's legislation introduced every year, and there was again this year. I think Tammy may have shown it on one of her initial slides. There was I think SB 1139 that established required the health department to convene a task force, which is basically to consider what's the impact of a dual use system, so meaning a recreational and medical use system, what the impact of that would have on patients and medical use.
Gotcha, thank you. There's a question in chat whether are specific strains prescribed for medical conditions, or do they just get access to all the products?
I'm sorry, could you repeat that?
Oh, so are specific strains prescribed for medical conditions, or do they just get, or do patients just get access to all the different types of products?
So yeah, doctors, they don't technically prescribe a type of cannabis product. So when they do go into the dispensary, the patient is open to all of the products that are available at the dispensary.
And I think some physicians, take a stronger stance on overseeing what their patients, the patients they certify use, but a lot of them actually do rely on the dispensaries to advise their patients. I mean, the general message always is, to start with a very low THC concentration product, and to, slowly increase, and basically just to use enough to provide relief from whatever symptoms you are experiencing. Other states do, though. Other states actually require a licensed pharmacist to be present in each of their retail dispensaries. So it's a variety. Every state's system is different.
Okay, thank you. I think there's a slightly related question asked by John, which is, if a patient visits a dispensary but doesn't know what to buy, does the dispensary staff offer advice? Or is there a policy that the dispensaries refer them back to their certifying physician? So I guess more questions about how the process actually works in terms of the specific product.
The dispensaries will provide suggestions. I mean, they will ask things like, if what form the patient wants to use. Like, do they want a tincture that they can just put a couple of drops under their tongue, or uh, for some patients, obviously, if they have respiratory conditions, then the dispensaries would suggest that they not use smokable forms. And I guess it really depends on what kind of relief the patient is seeing, right, is seeking. But it varies. And then there are a couple of the dispensaries, there are apps that patients can choose to register in. And what basically the apps do is the patient can enter the type of the type of condition that they have, or the type of symptom that they're seeking relief for. And then they will enter the specific product that they purchased, which dispensary they bought it from, and how they used it, how much of it they used. And they will provide comments about whether it provided the relief, or if there were any unpleasant side effects that they had from the product. And the patients can choose to register into that system. And so they, in that way, they kind of share their experiences and the information that they have, and and serve as a resource for other patients.
Awesome, thank you. There's a question from Greg about whether you see a conflict of interest with producers of cannabis being the retailers and default advisors as to what product to consume, kind of like Purdue Pharma recommending painkillers.
That has been raised as a concern. I think the reason why it's not been as strictly regulated is just because of there really is so much information that's lacking right now. There's no standard dosaging information for any of the cannabinoids, really. I think CBD, there's probably a little bit of there's some information, just because it's the only substance that actually has been FDA authorized. But with regards to literally the hundreds of other cannabinoids that are present in the plant, there is no information with regards to dosaging. So it's really difficult to be able to put in strict requirements. But I could foresee that coming, as we learn more about that.
Thank you. I think we're almost running out of time for the Q&A, but there's a few questions that I think you could be able to quickly answer. One from Lisa Blair about, are dispensary clients given the information regarding the risk for psychological effects and overdose with products containing high levels of THC?
No, not currently, and that's something that we are looking into with regards to the health education. There are requirements on the warning label, but they are very minimal, and we are looking at expanding that requirement.
Thank you. Okay, one last question, which is, doesn't higher THC mean lower CBD, which I understand is the pain relieving component?
Traditionally, in the plants, that was the case. However, the plants are bred to to adjust. I mean, they've been doing a lot of breeding of the plants to adjust the relative concentrations of the cannabinoids in the plants, and that would be the case for just the flower material. But of course, they do produce extracts, and the extracts can be mixed, so that say they can produce a tincture that is 1-to-1 THC CBD concentration or 2-to-1. So because they can manufacture products that have a known concentration of a specific cannabinoid, they can actually mix to provide formulations that have specific concentration ratios of those products, those items.
Gotcha. Thank you so much. I think that wraps up our Q&A section. And once again, just wanted to say thank you so much, Tammy and Michelle, for the wonderful presentation. And we're now going to move on to closing remarks. So our next meeting is scheduled for Thursday, August 19th from 1 to 3 p.m. via Zoom. And the following meeting is scheduled for Friday, November 5th from 1 to 3 via Zoom. And for more details, such as the speakers and the registration links, please visit our webpage, which you can see on the screen, which is go.hawaii.edu/grj. The G and the J are capitalized, R is lowercase. And if you have any ideas for future speakers who would be willing to share data related to substance use, please let us know by sending us an email, which is, you can also see on the screen, is piac+uhseow@hawaii.edu. And we'll be more than happy to reach out to anyone that you think would be a good fit. And with that, yeah, that concludes our SEOW quarterly meeting for May 2021. Please stay safe, everyone, and we'll see you in August. Enjoy the 3-day weekend.
Thank you.
Bye. Thank you.